Thank you. Thank you. Thank you, chairpersons, for the kind introduction. Thank you, Dr. Bashi Sabu, for organizing this wonderful conference. My heartiest congratulations to all organizing team. So let me talk about the beta blockers and cardiovascular continuum in diabetes. I think beta blocker is the drug which is highly used but most criticized, especially in the world of diabetes. Very few physicians would be anywhere who are not using the beta blocker. But they still say that beta blocker should not be used in the diabetes patient. So let me tell you something about that. So individuals with diabetes are at a significantly higher risk of developing cardiovascular diabetes. It's really not a new thing. And the conditions like hypertension, coronary artery disease, and heart failure are very commonly seen in diabetes patients and much earlier than any other comorbidity. Beta blockers are a class medication commonly used to manage various cardiovascular diseases by primarily reducing the heart rate, blood pressure, and myocardial oxygen demand. While beta blockers are effective in managing CVD, their use in diabetic patients requires careful consideration due to its potential effect on blood glucose level and masking the symptoms of hypoglycemia. And that is the biggest problem because of what we always remain afraid of the beta blocker, especially in the patients of type 2 diabetes or any kind of the diabetes. 7GNC recommended that blood pressure in a diabetic patient be controlled to level less than 130/80. And nowadays, lot of organizations are there who are saying that blood pressure cutoff should be less than 130/80. Probably the INCH guideline what Dr. Sandeep Tak has presented right now, next time when they will be revising, they are also coming on the same line 130/80. And in fact, it was a proposal at that time also. A lot of evidences were also there, but many of our senior colleagues were not really made up their mind to bring the blood pressure at so low to make it normal. So that's why many times consensus is always a thing where nobody agrees upon. So this is a old proverb. The consensus is a thing where nobody agrees upon. So many of the times people, those who don't agree for something, hypertension is a common comorbid condition of diabetes which affects 20 to 60% of patients with diabetes depending upon ethnicity, age and obesity. So let's understand what is cardiovascular continuum. I think many of us will appreciate this thing and will agree of this idea when a person gets diabetes about 15 years before he starts developing the endothelial dysfunction. And endothelial dysfunction is the first thing of insulin resistance or kind of first adverse consequence of the insulin resistance which starts happening. Means a person if he is developing diabetes at 30 years of age, at 15 years, he starts having the endothelial dysfunction. And this is the background or you can say the foundation of the endothelial dysfunction that includes dyslipidemia, hypertension, diabetes, obesity, smoking. Smoking is a thing which is out of the metabolic syndrome, which adds up the endothelial dysfunction occurrence to all this cardiovascular continuum, which ends up to the atherosclerosis, leading to CAD, ischemia, angina, coronary thrombosis, MI, arrhythmia, remodeling, then ventricular dilatation, and finally chronic heart failure and end-stage heart disease. Beta blockers can intervene at many points in CV continuum, since from the very beginning. So beta blocker is a drug which can have its effects which can interfere in this CV continuum at the stage of the left ventricular hypertension, at the stage of the CAD, what many of us will agree upon, MI, coronary thrombosis, arrhythmia, remodeling, ventricular dilatation, and of course the heart failure. And now the things has established up to the so much new learning which has made us the old learning unlearn. When we were doing the MD, beta blockers were contraindicated for the heart failure. And now this is the most preferred drug for the heart failure. So cardiovascular continuum in diabetes is established by the increased CV risk, Diabetes significantly elevates the risk of the cardiovascular disease like hypertension, CAD, heart failure. What the pathophysiological mechanism that makes it possible is, of course, a chronic hyperglycemia or insulin resistance. Even without chronic hyperglycemia, leads to the endothelial dysfunction, oxidative stress, and inflammation, which contributes to the development of atherosclerosis, myocardial damage. Insulin resistance and dyslipidemia makes the foundation of the arterial stiffness, increasing the risk of the MI and stroke. Finally, the diabetic cardiomyopathy leads to the structural and functional changes in the myocardium known as the diabetic cardiomyopathy resulting in heart failure and arrhythmia. And beta blockers are important role plays in managing the cardiovascular complications in diabetes by reducing heart rate, blood pressure, myocardial oxygen demand, and mitigating the progression of the CVD. So this is the background of all what we understand in the name of the contribution of the CVD in diabetes and how can it be interfered by the beta blocker. So once the problem starts with the IR and obesity, you can, sorry. Right. When the problem starts with the IR and obesity, and this is the situation where multiple things start occurring together, like increased free fatty acids in the liver, release of the non-esterified free fatty acids in the muscles, where we see that macrophages infiltration, lot of inflammatory markers, insulin resistance, and oxidative stress, fat deposition. These all everything are not only happening at the muscular level but also in multiple organs in the body. That includes the adipose tissue, that includes the pancreas, that includes the liver, heart, and kidney. All. And this hyperglycemia, which is ending up with increased level of the polyol deposition and increased advanced glycemic end products, this actually makes the foundation of diabetes, cardiovascular continuum in diabetes. Now question arises that how does beta blocker interferes and works here? Beta blockers affect the receptors in the heart and blood vessels, acting on the adrenaline and noradrenaline receptors, which are acting on the cells in the heart and blood vessels, where is they are interfered by the beta blocker receptors, and that's why it slows the activity of the SA node, which initiates the heartbeat, and we see that tachycardia is controlled, heart rate slows, and left ventricle, and it allows the left ventricle to fill completely and lowers the heart workflow. Beta blockers finally dilate the arteries, lowering the blood pressure. Beta blockers, when it is compared with the other medications in the diabetes, we see that beta blockers reduces the heart rate, blood pressure, arrhythmia. They could be best for reducing the CV risk in heart failure, CAD, and post-MI. At the other end, the most preferred drug, that is the ACE inhibitors and or ARB, they are supposed to be improving the kidney and heart protection. They are the first line in hypertension and coronary artery disease. And in fact, now they are the first preferred drug even in CKD. Calcium channel blockers, which are supposed to be having effects on the vascular tree by vasodilatation, controls the blood pressure, most effective in blood pressure control. Hypertension with angina is the best for the cardiovascular risk to be used it. And last but not the least, SGLT2 inhibitor is now recommended not only for the diabetes but also for the hypertension management as well as the correction of the CV risk continuum even in non-diabetic individuals, which improves the patient, those who are suffering with heart failure, and improves the renal outcome in the patient of CKD, as well as it is best for reducing the CV risk in heart failure with diabetes. So once it is heart failure with reduced ejection fraction, MERIT-HF trial, which was the randomized control trial, reiterated the clinical benefits of the metoprolol, controlled release, extended release in patients with heart failure with reduced ejection fractions. Adding carvedilol to the standard therapy of heart failure could be able to reduce the mortality by 35% in the Copernicus trial. The study also showed the consistent benefit of the beta blocker therapy across all strata. Considering dose-dependent survival benefits of the beta blocker, the clinicians are advised to titrate the dose to its targeted dose or maximally tolerated dose, whatever is feasible. If we talk about the CAD, early administration of the IV beta blocker therapy in conjunction with the percutaneous coronary intervention improves the LV function, reduces the incidence of the malignant arrhythmia, decrease long-term heart failure, and of course, readmission. Or you can say that hospitalization by the heart failure. Considering the mortality reducing intervention in post-MI setting, the European Society of Cardiology guidelines recommend the administration of the oral beta blocker as class 1 recommendation. Within the first 24 hours in all the patients with ST elevation MI except those with signs of the heart failure. Evidence of the low output state increased risk of the cardiogenic shock or other contraindication to using oral beta blocker. Oral beta blocker therapy has been recommended for all NSTEMI, means non-ST elevation MI patient without pre-existing contraindication. So effects of the beta blockers on all-cause mortality in patients with diabetes and CAD. A systemic review and meta-analysis has shown that application of the beta blocker improve all-cause mortality and cardiovascular death in coronary heart disease, especially in cases of the MI and diabetes mellitus patient. Beta blockers application significantly reduce CV death. According to a network meta-analysis, beta blockers were superior to other antihypertensive medications like RAS blockers, calcium channel blockers, and renin inhibitors. Evidence demonstrated that significant reduction in all-cause mortality and CV endpoints with beta blockers therapy for treating CHF in patients with CKD. Another study has reported a lower risk of the major adverse cardiovascular events and ischemic stroke with the use of a cardioselective beta blocker. So efficacy of the beta blocker across different cardiovascular indications. An umbrella review, which has been used as a meta-analysis assessment in heart failure with reduced ejection fraction, 34 meta-analysis has been pulled up and demonstrated a reduction in mortality and heart failure hospitalization with beta blockers in sinus rhythm. Selecting the right beta blocker in diabetes always remains a challenge, how to find the best one for our patient. Heart failure with reduced ejection fraction, beta blockers like metoprolol, carvedilol, bisoprolol are recommended to reduce the major adverse cardiovascular events with CCD and LVEF, left ventricular ejection fraction, less than 40%, regardless of the diabetes status. If we are looking for a patient of the post-MR, for patient with coronary artery disease and left ventricular ejection fraction more than 50% post-MI, it's a long-term or up to 1 year use of beta blockers may be reassessed, especially in the absence of angina, arrhythmia, or uncontrolled hypertension. Stable ischemic heart disease without heart failure or prior MI. Beta blocker therapy is not routinely recommended for reducing major adverse cardiovascular events in patients without prior MI or ejection fraction less than 50% unless there is another primary indication. So diabetes, especially in the presence of diabetes, beta blockers are effective in managing cardiovascular conditions. Clinicians should monitor diabetic patients for the potential impacts on the glycemic control, especially for the hypoglycemia or masking of the symptoms of the hypoglycemia. And now when we are having so much of the diabetes medication which is hypoglycemia free, like DPP-4 inhibitors, like GLP-1 receptor agonists, like SGLT2 inhibitor, now that problem which was supposed to be arising because of beta blocker is not there. So if we talk about their comparative account, cardioselective beta blockers like metoprolol, bisoprolol, atenolol are found generally safe in diabetes. They have got the lower risk of the masking hypoglycemia symptom compared to non-selective beta blockers. Non-selective beta blockers includes the propranolol, nadolol, and timolol. They should be used with caution because they are masking the hypoglycemia symptoms and affect the glucose metabolism. Blood glucose monitoring is required multiple times or frequently. Beta blockers with intrinsic sympathomimetic activity like acipitol and pindolol should again be used with caution, may have less impact on the resting heart rate. However, their role in the diabetes management is limited. When they are combined with the alpha blockers like carvedilol and labetalol, potential benefits in patients with diabetes. Carvedilol improves the insulin sensitivity, monitor blood glucose level is to be required. Safety profile. Research demonstrated a negative association of prior beta blocker use with the incidence of severe hypertension during severe hypoglycemia, a potential lethal combination that may contribute to the increased risk for the CVD or mortality. Increasing beta blocker dose is associated with a greater prognostic advantage in CHF patient with diabetes than in CHF patient without diabetes. The mortality reduction is the benefit. Beta blockers in the management of hypertension in patients with type 2 diabetes, it could be seen that they are effective antihypertensive agents which in long-term studies have proven beneficial in reducing important clinical endpoints. However, non-selective beta blockers may have a negative effect on the lipid profile and contribute to hypoglycemic unawareness, thus preventing their use in some patients with diabetes mellitus. So we have to be selective for choosing beta blockers. In subjects with type 2 diabetes and systolic heart failure, they does not worsen the glycemic control. Beta blockers did not worsen the glycemic control, lipid profile, and albuminuria status in patients with diabetes and systolic heart failure, suggesting that these medications should not be withheld in this group of the patient. Significantly improved glycemic control in patients with type 2 diabetes and systolic heart failure while using the carvedilol could be seen, and this improvement was not significantly better than that of the obtained with the bisoprolol. Current guidelines, which are for the beta blockers used in diabetes, American Heart Association or ACC 2022, they says that beta blockers are recommended in heart failure, post-MI and arrhythmia. European Society of Cardiology suggests carvedilol, bisoprolol, nebivolol are preferred in diabetes. ADA 2024, beta blockers to be used with caution, especially in insulin-treated diabetic patients. INCH guidelines, what Dr. Sandeep Thakur was also discussing before my talk, in case of a recent MI, a beta blockers may be added. Future perspective of the beta blockers, if we look for that, we need a targeted research. Further studies on the beta blockers' effect on the glucose metabolism, insulin sensitivity, and inflammations are needed. Now the time is changing. Now we are moving to the era where we are having a lot of anti-diabetic without hypoglycemia. The beta blockers and its use should again be redefined. A lot of clinical trials are already there, but we will further need some of the large scale trials should assess their long-term impact on diabetes and CV outcome. Evaluation of the different beta blockers like carvedilol and metoprolol can optimize the treatment selection. Personalized medicine. Now we are heading towards the era where we can look for the individualized medication even for the diabetes management. Seem to be for the cardiovascular risk management by using the beta blocker. Genetic and metabolic profiling of individual may help tailoring the beta blocker therapy. Risk benefit analysis could be achieved by more research to balance beta blocker cardiovascular benefit with potential metabolic risk. Thank you very much for your kind listening.